back to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I am your host, Amanda Mixon, here with Audrey Gibson, and this is part 3 of our EULAR Psoriatic Arthritis RhAPP Up. We've covered some interesting information thus far, and in this final episode, we will wrap things up. Let's go ahead and dive in. Abstract 0747. 2-year treatment persistence among patients initiating first-line advanced therapies for psoriatic arthritis. The overview of this study, this real-world observational study evaluated long-term treatment persistence, switching, and discontinuation rates among patients with psoriatic arthritis initiating first-line advanced therapies. Investigators compared persistence across multiple mechanisms of action and individual therapies over a 24-month period using U.S. claims data. The background of this study: psoriatic arthritis is a chronic inflammatory disease requiring sustained disease control to optimize outcomes. While multiple advanced therapies are available, treatment persistence in real-world practice can vary considerably and may reflect treatment effectiveness, tolerability, and patient satisfaction. Previous analyses suggested higher 1-year persistent rates with risankizumab compared with other therapies, but long-term data was limited. This study aimed to evaluate 2-year persistence across advanced psoriatic arthritis therapies and MOAs. The methods: this retrospective observational study utilized the Merative Market Scan database and included adults with psoriatic arthritis initiating a first-line advanced therapy between 2022 and 2025. Outcomes assessed over 24 months included treatment switching, discontinuation, and persistence. Therapies were analyzed both by MOA and by individual drug. Persistence was defined as remaining on therapy without switching or discontinuation. Multivariate logistic regression was used to adjust for baseline differences between treatment groups. The results were that among MOAs, IL-23 inhibitors demonstrated the highest treatment persistence at 24 months compared with IL-17 inhibitors, TNF inhibitors, and PDE4 inhibitors. IL-23 inhibitors also had the lowest rates of switching and discontinuation. At the individual drug level, risankizumab demonstrated the highest persistent rate at 51.6 and the lowest rate of treatment switching and discontinuation compared with all other evaluated therapies, including guselkumab, secukinumab, ixekizumab, adalimumab, apremilast, and etanercept. Adjusted analyses showed significantly lower odds of persistence with all comparator therapies versus risankizumab. So the authors' conclusions were that in this real-world analyses, IL-23 inhibitors demonstrated greater long-term persistence compared with other advanced therapy mechanism of actions for psoriatic arthritis. Risankizumab in particular was associated with the lowest rates of switching and discontinuation and the highest persistence over 2 years. The authors concluded these findings support the potential benefit of risankizumab as a first-line advanced therapy option in psoriatic arthritis. So, Audrey, what are your first thoughts with this?
So it's real world data, right? Claims data. And so there's several things, the benefits of claims data is you have large number, patient population that you can pull from, right? So there's that, that increased number, there's strength there. But on the other hand, you don't know exactly why these patients discontinued therapy or why were they switched. We just know that they didn't continue on therapy. And that could be, because the medication didn't work. It could be because they had a side effect. We don't really know. But it was really interesting that risankizumab was the one that had the highest persistence over that 2-year period. And again, when you're trying to pick the drug that's going to work for patients, but that they're going to be able to stay on, then that would suggest that patients continue to do well on it after a long period of time and that they generally tolerate it well. They didn't have any major issues or side effects there. So again, I think it's helpful data, and it can, again, it kind of can help you when you're making that treatment algorithm. What do you think?
Yeah, I always like real world
You too.
data because what happens in a clinical trial is different than what I think a lot of times we're doing in again, the real world and the variants and all of those things. And I, again, I love when trials and studies come out that are consistent with what I am seeing in clinical practice, because it obviously reinforces that what I'm seeing is actually what everybody else is seeing.
Yep.
And I do see that with the IL-23s. I mean, I think people generally do well with them. I don't tend to see a lot of tolerability issues.
Mhm.
And that means something. I mean, we certainly have therapies that are excellent therapies, but there are tolerability issues. And so, I do tend to see that with the IL-23s, that tolerability does not seem to be the driving factor of why we might switch to something different. And that's actually what I tell my patients too. When we start either IL-23 agent, I will tell people these are generally, again, very well tolerated, from a safety perspective, again, tolerability, etc. People that started the trials tended to stay in the trials, which
Yeah.
means something. And I think that gives patients that, it puts their minds at ease, particularly if this is their first biologic,
Yeah,
because
absolutely.
already they're like, I have to inject myself with something, and that's scary in and of itself. But they certainly don't want to think, I'm going to inject myself with this drug and then potentially have some kind of terrible side effect that I would have to stop it. Um, and so, again, I can't say that this was, overwhelming, or surprising to me because that's actually what I see in clinical practice.
I agree.
Awesome.
Well, let's get into the second abstract here. So this is OP0184. This is a phase 2B trial of the selective TYK2 inhibitor zosicitinib, which is TAK-279, in active psoriatic arthritis. Biomarkers associated with pathway modulation, disease activity, and clinical responses. So the overview of the study is this is a phase 2B post hoc analysis, evaluated the biologic and clinical effects of zosicitinib, an investigational oral selective TYK2 inhibitor in patients with active psoriatic arthritis. The study specifically explored how biomarker changes correlated with disease activity and clinical response to therapy. So, the background here is that TYK2 plays a central role in inflammatory signaling pathways involved in immune mediated inflammatory diseases, including psoriatic arthritis. Zosicitinib is a highly selective allosteric TYK2 inhibitor currently in development. This analysis aimed to better understand the relationship between TYK2 pathway modulation, inflammatory biomarkers, bone remodeling biomarkers, and clinical response in patients receiving zosicitinib. This is a multi-center, randomized, double-blind, placebo-controlled phase 2B study enrolled 290 patients with active PsA. Patients received placebo or zosicitinib at doses of 5 milligrams, 15 milligrams, or 30 milligrams daily for 12 weeks. Blood samples were collected at baseline, week 4, week 12 to evaluate biomarkers related to TYK2 signaling, inflammation, bone formation, and PsA disease activity. Clinical response was assessed using an ACR20 clinical response criteria. So the results were that treatment with zosicitinib, 15 milligrams and 30 milligrams, resulted in early and sustained reductions in biomarkers associated with TYK2 signaling and PsA disease activity, particularly among patients achieving ACR20 responses. Biomarker changes were evident as early as week 4 and generally persisted through week 12. Patients with elevated baseline inflammatory biomarkers, including IL-6 and IL-22, demonstrated greater likelihood of achieving clinical response with zosicitinib versus placebo. Additionally, zosicitinib appeared to attenuate increases in bone formation biomarkers, suggesting potential effects on structural disease processes. These biomarkers improvements were most prominent in clinical responders and were not consistently observed in placebo-treated patients or non-responders. So the author's conclusions here were that zosicitinib demonstrated meaningful modulation of the TYK2 pathway and PsA-related biomarkers in patients with active PsA, with biomarker changes correlating closely with clinical response. Baseline biomarker profiles may help to identify patients more likely to respond to TYK2 inhibition. These findings support continued development of zosicitinib and further investigation in ongoing phase 3 clinical trials. All right, so a lot here. What are your takeaways?
Well, in a previous abstract, you talked about precision medicine. And the very first thing that caught my eye was checking these biomarkers and how I hope there will be a day where we can check biomarkers in patients and see that this particular patient is really high in this interleukin, and this patient may be really high in this one. And I think that that will help us choose therapies. So right at the beginning, I thought, wow, this is really cool that they're doing that and they're looking at this in patients to potentially see who is going to respond the best to this particular therapy. So I kind of thought that that was really, really neat, and something that is so needed as we think about patients, particularly as we have more and more options. Which again, this is another option potentially for us for patients. I also find the TYK2 pathway really interesting. As we kind of look at this and the JAK-STAT pathway, and even from a safety perspective, kind of thinking about these as potentially being the safer JAK inhibitor. And so I think that this, is really interesting data, and hopefully will be another option, another safe option for our patients.
Yeah, that's really where my mind went. I thought if we have a way to see a patient, sit down with them in the office and say, okay, this patient has a higher likelihood to respond to this medication based off, biomarkers, lab tests. Again, the implications for that for patients, for their response, again, how they do long term, preventing disabilities and deformities. I think that the huge clinical impact to help guide us. Hopefully, insurance will allow us to do that. If we can prove that this patient is going to respond better to this drug, that we will be able to get that medication for that patient. I think that also is a huge impact for patients. And then I think too, again, we have this new pathway, right? Potentially safer pathway than our JAKs. And, if it has the same efficacy with a better safety profile, again, I think that's really clinically relevant for taking care of patients. I think time will tell. We need more data. I think it was a phase 2B. So I'm sure they're exploring that in larger clinical trials, phase 3 trials. So I'll be excited to see kind of what comes of that in the future.
Me too. Well, that brings us to the end of our EULAR Psoriatic Arthritis RhAPP Up series. A huge thank you to Audrey for joining us and sharing her expertise across the series. We hope this series helped break down the most important updates of psoriatic arthritis from the 2026 EULAR Congress and gave you some valuable takeaways for your clinical practice. If you've enjoyed this episode, be sure to follow RhAPPcast so you never miss an update. And don't keep it to yourself. Please share this podcast with your friends and colleagues. You can also follow RhAPP on social media for more education, updates, and community discussions. Find us on LinkedIn under Rheumatology Advanced Practice Providers, Instagram and X under RhAPP, and Facebook. And we're also on TikTok now, so that's pretty exciting. Thank you again for tuning in, and we will see you next time on RhAPPcast.